welcome everybody. This is a in-services unexpected. As you all know, we had an unexpected visit from Medicare. But we've gotten to a point where 90% of the time we're running operations right where we're supposed to regulation-wise. And so at least I don't panic as much as I used to 20 years ago. I was like, they're here. So it's a little bit easier now. And there are, usually they find something that, we just say, we forgot that or we didn't know about that. Either way, they came. And from a regulation standpoint, just want to remind all of you that do take pride that you've chosen to work at a facility that really makes an effort every single day and on an annual basis to operate, within compliance, within regulations. Do we miss some regulations sometimes? Absolutely. You're going to notice that this year. But by and far, we're pretty even keel. We take the time to literally bring operations to a stop. And then bring all of you, because it's worth it to us. If you can all hear it at the same time, it makes a huge difference. There's enough research that says if everyone hears it, everybody's going to hear a little bit different, but you tend to ask your colleagues, hey, this is the way I understood, so a lot more effectiveness and follow through. So this is to us worth stopping. This is an unexpected, unplanned meeting. It is going to take exactly 1 hour. There are going to be 2 presenters today. It'll be myself, and then Amanda will follow. And everything is related to the Medicare survey response. We're not going to talk about other things that we need to talk about. We'll do that in May. But before I continue, I do want to welcome 4 people to our team. At the east side, we have Crystal. So Crystal, if you can raise your hand. She's helping us in the front office. We have Alma helping us at the front office too. So she's up there taking Monica's place for right now. On the west side, Adriana, there she is, thank you. She's helping us on behalf of Jessica's maternity leave. We have Christopher that came back. Where are you, Christopher? Thank you, welcome back. Thank you for helping us. And the reason Christopher came back is that we'd like to say officially goodbye to Joe. So Joe, you want to raise your hand? He's leaving us. Thank you for all the service he gave us. And Thursday is his last day. And he truly is going to a really good place. I love when employees leave for this reason. So we wish you the best as you bridge over into the DPT program at UTMB University. So we've blessed him already here on the east side. So remember, because it's not easy to go through that. So thank you very, very much. You also will not be seeing Larissa. She leaves us at the end of April, and she got accepted to the DPT program at UTEP. So, so thank you. Some changes, but they're fun and worth it, and that's where we want y'all to go. Go after your dreams. All right. Let me walk you through a little bit of, some of you may know this already, but I'd like you to be aware of what occurs. So Medicare comes. There are approximately 122 standards for an outpatient rehab physical therapy facility that we must always adhere to. There are, I think, 14 sections, and the 122 standards are unveiled in those 14 sections. They look at each standard methodically and see if we are in compliance or if we're not. They divide it into 2 categories wherever they go in the United States. Those that are life-threatening are one classification, and they have to be resolved within 30 days, and then they call them non-threatening contingencies that you did not meet, and you have 60 days to do that. So it is 60 days from the time that they arrive. But because they tell you at the exit interview where you were deficient, you have to get started right away. 60 days lands exactly next Tuesday. So what we decided to do is make it 1 week before, because we still need to teach the technicians. The other thing we do is that we have to reply, give them a response, and then and all that goes through the legal systems. Now, go through 2 steps for getting recertified. You can still operate if you have non-life-threatening conditions. In this particular case, it goes back to Austin, Texas, which is where the state sends all the surveyors, and then once they have reviewed and accepted it, then they send it to CMS in Washington, D.C., and that's how it travels. And that can take anywhere from 60 to 90 days. They did something extremely unusual. In all the 38 years that I've practiced, I've never seen them do this. And this time, when we responded, Monica and I, to all of the deficiency that they identified, they came back and said, we want to see your plan. And it's like, and never have they done that. They've always accepted whatever my verbal is. And almost all of them said, the board will be informed of the changes that we're making on April the 2nd, assumed in the morning, because that's when Rudy and I and Sylvia met this morning. And then the staff will be taught on April the 2nd with all the education. So they've usually, and I identify what we're going to be teaching, but this time they wanted us to submit the plan of what we were going to teach. Thank goodness we had it all done. Someone has sent it out. We haven't heard back from them, but no news is good news. I am pretty sure that they'll accept it. So, moving forward, let's talk about where we got cited. So, the agenda for non-conditional deficiencies, this is what we were identified as not having. Number one, they said you're not very clear in your policies and procedures that you have an administrator that is appointed on a full-time basis and who's a qualified one. And even though we have it in our organizational chart, the question that they had is, part of the regulation is, do you have someone, does the administrator appoint someone in their absence in case something happened? And we could not prove that. So we'll talk a little bit about what what we're doing as a company regarding that matter. The next one is that when they went to one of the 14 categories, which is medical record content, they consistently said, we do not see that you have a prognosis at time of discharge. I do want to tell all the PTs that they commended us on the content of our evaluation. That they did say. But we completely missed the prognosis at time of discharge. I'll talk about the plan that we have there. And then the last thing is the new buzzword. Since 2017, there had been an emergency preparedness plan that I absolutely was not even aware of. So this is my responsibility. It's a little hard to swallow, but it goes to show, don't ever be afraid to make a mistake. You just own it and then take care of it. Okay? So we did not have the emergency preparedness plan as described by CMS and FEMA. So we will work on that. It was so we had to revise the policy and procedures in the safety and health section, and then as a result of that, we had to revise the in-service manual, which Amanda will take care of that component. Okay, in terms of the administrator, I'm not going to spend a lot of time, but this is how the standard reads, that the governing body appoints a full-time qualified person, and then this is where, and designates a competent individual to act during the temporary absence of the administrator. So that was not in place. Just do want to let you know that Rudy and I carry a dual administrative role in the company. He is administrator number 1 and I'm number 2. And just in order, just because that's the way we wrote back. And so when Rudy is gone, it says that administrator number 2 will be the person to act in a temporary absence, and then vice versa. If I'm absent, he acts on that. So that's the standard. We wrote it back, as you see here, administrator 1 and 2. This is the way our policy and procedure is now going to read in section 100.0020 if you're ever interested. But so we'll take care of that, and Rudy and I continue to have a heart for administrating this company. We do everything we can to make sure that it's running smoothly, and that our operations are nice and tight, and that the employees understand why we have to operate the way we operate. All right, the next one is medical record content. I didn't copy everything, that's why I put ... but on the standard it says that all clinical records must contain all of these 7 elements. We had all 6 of them to perfection. So thank you, PTs, kudos to all of you. But number 7, we were absolutely missing the discharge summary, including the final diagnosis and prognosis. The reason that I'm putting diagnosis in black is they didn't catch us on that one. Because your discharge note is done under Optimus, and Optimus has the diagnosis on top, we met it from this angle. What we didn't have is the discharge summary. So this is our recommendation to the company, not the recommendation, the new procedure. So we responded and we said that we've now changed our policy and procedure manual. All of the 300 series in our P&P manuals do relate to medical record documentation. And so the new procedure for us is going to be the discharge prognosis will be included in the assessment section of Optimus. Do not put it anywhere else, so that when we get audited, we go straight to assessment. I've been practicing with it, so has Rudy. You can create templates, share your templates, but I decided to create a template that says prognosis in caps, and then I'm playing with just a temporary sentence, and just has to be done. Now, for all the absent discharges, PTAs, all of you legally can gather data for us. You just can't close so I know that at the east side, PTAs do assist the PTs in the absent discharge. You need to include this. So Joe, before you leave, make sure your little templates have been changed so that it includes the prognosis. And get creative. I'm not going to stand up here to give a lecture on prognosis. I mean, if they're good, if their prognosis is good because they're going to continue to improve upon their condition with a home exercise program, that's fine. But if their condition is not good, you need to say that, or fair. Just get it. Just start playing with it. APTA has an excellent section on prognosis at time of discharge. If you want to take some time to read it, feel free to do so. But that's what we're going to do. Okay, so we talked about discharge for an active patient that we actually get to discharge on that day, and absent discharge. All right, let's go on to the next section. Right, this was the big one. This is where we were missing on. So it's called Emergency Preparedness Plan. This is the new buzzword, is preparedness. So our policy manual used to say emergency plan, and now it's changed to Emergency Preparedness Plan. This is the standard. It's outside of the rehab medicine, the 122 standards, 14 sections. That's why I didn't even know it existed. It's in a completely different category that the healthcare should see. I believe it's HHS oversees this category in Washington. So it's for outpatient physical therapy. This is a standard, and it's called Appendix Z. There are 22 standards in this category. By God's grace, and I really do want to say it was His grace and gave us enough wisdom. Of the 22, the only thing is we did not pass 3. So luckily, the existing emergency plan that we had met 19 of the standards, based on the surveyor's perspective. So again, thank you for all of you who so methodically every month have in-services that relate to your in-service manual, because it crosses over into all of the safety and health. Our response is that we told them that the compliance staff members of this organization began the improvement process plan immediately, and upon approval of the revised plan, the organization's executive board members and the compliance training staff will provide an in-service to the organization. Kind of what I told you. So this is what we told them about 3 weeks ago, and the day has arrived. So we are going to be talking about this part. Okay, let's go. And this is the way we felt, Monica and I, this would be the best way to unveil it. We're going to do it in 2 tiers. Tier 1 is today, and then you're going to have a follow-up meeting this week with your technicians. So everyone's going to come. I'll go a little bit more into detail, but we thought that would be the best way to unveil it. Currently, when the surveyors came, this is page 1 of 2 of the table of contents. So we corrected these 3 areas, and the 3 are emergency preparedness procedures. The second is all hazards risk assessment, and the third, volunteer staffing, and then the third is primary or alternate means of communication. All those words don't mean anything to you right now, like they didn't mean anything to Monica and I at the beginning. It was with a collaborative effort, and we thank Armando, thank you, my dear. He did such an incredible amount of research with FEMA so that he got the vernacular, then we brought it in, and then we included it in our survey. So Eastside team, thank you, because I probably have been physically here, but not mentally, but we've made it. We made it this far. So these are, I'm going to explain how Medicare uses these terms, because they're very different to us. And when somebody tells me emergency preparedness, what does that mean? A lot of this came out of the birth of the hurricanes out of Florida, and then picked up speed tremendously when the Houston had its flood. But I don't know if any of y'all remember in the news, there was a SNF unit. It was one level, their floor, there weren't multiple levels, that got flooded, and the elderly just stayed in a wet bed because they didn't have an emergency preparedness plan on how to exit them out of that and move them on to another place. So lots of complaints to Health and Human Services Division in Washington, and thus a lot of readiness was thrown at the entire section, that cabinet section, and then of course trickled all the way down across the country. All right. What happened here? Well, this is the way your safety and health is going to look. Anything that's in red, for those of you who have the copies, anything in red is what you have to teach your technicians. Everything else is pretty much the same. So on the all hazards risk assessment, so when they use the word all hazards, this is where they're coming from. They're saying you might have here, let's just use this clinic. This clinic may, and it's happened, we just have a storm and it just, all the lights go off here. So yes, we're taking care of the patients, we unplug everything, you know, we make sure that the patients are safe. So something else is going on besides that. The clinic director is making an immediate decision is how long is this going to take? Do we send our staff home? Do we keep them? Do we tell the patients to go? Do we have them exercise with the natural light that's coming in? They're calling Armando. Armando gets started on looking at the city region's status, you know, what's going on. And he has a phenomenal way of finding out, reports it back to us, and then we kick in and start making. Clinic director has to make a decision. Do I close the clinic down? Do I keep it open? Do I send my staff home? So decisions, always be real patient because the clinic director makes the final decision. And or, you're gonna see this inside in our plan, and or the appointed person. So all clinic directors here, on the day that you're not here, whether it's because your wife is going to have a baby pretty soon, I know that, or you go on vacation, or you're going on a CE course, somebody has to be appointed in your absence. It's very important, you know, just don't assume it's, I'm gone, this person's in charge while in my absence. And have already a standardized protocol because it makes it easy that way. Well, all of us leave when we have to leave. All right, so when it talks about all hazards, so right now if you notice I gave an example, all of this is just happening and nobody on the outside even knows what's going on. But if there had been a windstorm and a circuit fire had started and we had to exit everybody, now the community is going to start to know who we are. Do we have to call EMS, you know, the fire department? All that means all hazards and risk assessment. You have to assess the risks that are in place. And it's clinic directors, the pressure's on you to make calls. Do we call fire department? Do we not? Are we fine? Are we not fine? There's where you have to understand that's an all thing. And that's what was happening when these floods were occurring, these hurricanes. They just didn't know who to call. They knew what to do internally, but they didn't know who to reach and why to reach them. So a little bit of a definition as to all hazards risk assessment. I think that some of the most important key points that I'm going to put here, point out, again, the clinic director or an appointed person in their absence will identify all the risks or emergencies that the facility may reasonably expect to confront. So you have to make that assessment, and then you identify all potential disasters for the geographic region. If you have a windstorm coming, sandstorm is the big thing for us here in El Paso. So we have to be ready for sandstorms because our windows can potentially break. So be aware of those. That's one thing I wanted to mention on this one. Let's go on to the next. Just a continuation here. Utilization of a nearby healthcare facility or safe environment facility. Let's go down to this sentence. The type of service that is provided at EPPTS facilities is such that the outpatient services are not essential for continuation during an emergency. So we know that for now. The one thing that we did add, and we just added it this Saturday, Monica and I, so we didn't get it to you, the final one. We added one more sentence, is if the clinic director says it's a disaster because the building burned, then the next sentence is we will then transfer all our patients to our existing facilities or to facilities close to the region. So that's the other thing that we have to do. We have to make sure those patients continue to receive service. All right. Volunteers and staffing. Volunteers, y'all, for FEMA's purposes and Medicare are the fire people, EMS, the coroner from the county of El Paso, anybody who says we're here to work for the county or the city and we will come help you, they are considered volunteers. Okay, so just be ready to determine, clinical director, if indeed the outage is going to be for a long time, or if you need them to come in, you call them. So by definition, volunteers are external assistants, people who can assist us during a disaster. All right, the next one, it continues with the clinical staffing, pretty much the same thing. You identify your disaster, how long it's going to last, and if it's an emergency and you need clinic director, you just get going on calling 911 and getting the whole system. Everything pretty much stays the same. Oops, here's the sentence. So it's not in the other section, Armando, just remind me, okay? And thus, alternate facility to community services is not required, but look what we wrote here. Continuation of services will be transferred to other organizations, clinics, or to a facility that's closer to the patient. So know your clinics. Like for us, it would be Border, although I don't want to sit in there. But Border's real close to them, and there's a lot on Lee Trevino and then the orthopedic group. But get to know your surrounding facilities. Then primary and alternate means of communication. This one was like the surveyor told Rudy, okay, so your phones are down. And then Rudy said, well, I'll use my cell phone. And his answer was, okay, but the cell phone tower is down and you just can't get to it. What are you going to do? So we're going to do, after Armando's research, we're going to use walkie-talkies. So it literally made it to the manual. Here it is, walkie-talkie. FEMA allows walkie-talkies to be used, so we're going to use them. They only go to a 2-mile radius, but we can call the closest fire department 2 miles from us to call somebody else, okay? And that's how we're going to do it. He is going to be getting walkie-talkies. They're going to be housed in the clinical director's office. Just make sure you have batteries because we need to use them. And he's going to teach us. He's going to give the clinic directors a separate in-service to teach us how to use them. Okay. Notification and emergency protocol. When you all, especially all you team leaders who do a bulk of the teaching, one thing you're going to notice is the only thing that changed here is that we have to call the board members and the administrators of the organization. Now, they're the same people, so just need to call them. Both of them have to be called. And so that's very important. We changed, of course, the term volunteer here. And then the other thing that I think is real important is we have only the word wind, and it's wind and sandstorm. We included sand here. That's why I changed it to blue. So you'll just see where it changes. All this was pretty much the same. We just had to put it all in red so that they'll know that that's our notification process.